Hello students, I am Dr. Manish Soni, your dermatology faculty, and today we'll be discussing high yield dermatology questions. Let us begin with this discussion. Here in this question you can see that they are saying that picture of groin area is shown. The following appearance on Wood's lamp is seen. So Wood's lamp is one important instrument which is used to diagnose various conditions in dermatology, and one such condition is erythrasma. Now, erythrasma is caused by Corynebacterium minutissimum. This is a bacterial condition and generally involves axilla, which is the most common site, but it can also involve groin. And here you can see that these lesions are present in groin. How these patients present? They present with a rash. And when you examine these rash under Wood's lamplight, they produce coral red colored fluorescence. So this coral red colored fluorescence is seen, as you can see in this image. Okay. Now this is not the only condition where Wood's lamp is used. So there are various other conditions as well. So these are few important conditions which you can remember. In pityriasis versicolor, under Wood's lamplight, apple green or yellow fluorescence is seen. In erythrasma, as I already told you, coral red color is seen. In porphyria, where we collect the urine of the patient in a test tube and then we examine it, the color becomes pink. In vitiligo, ivory white. In ash leaf macules, which are seen in tuberous sclerosis, bluish white color is seen. And the most important one, tinea capitis, under Wood's lamplight appears green. So these are various colors which can be seen under Wood's lamplight in these various conditions. Moving on to the next question, here you can see that the examiner is asking that 54-year-old women presented with prominent scattered erythematous papules and vesicles. So vesicles are very small fluid-filled lesions on the right side. So the lesions are unilateral, only on one side of the forehead. She has burning pain with hypersensitivity in that area for the past 2 days. Her pain is localized to the right supraorbital area and the right aspect of the dorsum of her nose. She denies headache, mental status changes, and recent infection. What is the most probable diagnosis? So these are some clinical questions which are asked, and clinical scenario is very important to understand. So here a long history and the examination findings are given, and the important clues you have to take out from the question. So what are the important clues? First important clue is that the lesions are vesicular, so fluid filled lesions are present. They are unilateral, only on one side. You can see the other side is spared. The lesions are present only on one side. Now the patient is having pain. This is a burning pain which is present, and as you can see that the swelling is also present in the eyelids, and this is a painful condition. All of you might have guessed by now, yes, this is a case of herpes zoster, because in herpes zoster, which is due to reactivation of varicella zoster virus. So this condition occurs due to reactivation of varicella zoster virus, which causes chickenpox in the childhood, and later this virus lie dormant in the nerves and can reactivate, and this reactivation is known as herpes zoster or shingles. So this is a patient suffering from herpes zoster or shingles, where unilateral painful grouped vesicles are seen, and this is due to reactivation of varicella zoster virus. So that's why the answer here is varicella zoster, and the case is of herpes zoster. Now, how to identify the lesions? If you closely see the lesions, you will find that all these lesions are small, less than 0.5 centimeter in size. That's why we call them vesicles, and they are clear fluid filled. So these are vesicular lesions, and as you can see, they are grouped together. So they are grouped and they are painful. Now, similar lesions can be seen in certain other conditions also, like if they are present around lips, we call it herpes labialis. If similar grouped painful vesicles are present over genitals, we call it genitalis. And if they are unilateral, like we saw in the question, and they are along a particular nerve segment, that is dermatome, we call it herpes zoster. So here you can see that these grouped painful fluid-filled lesions are present around lips. So this is a case of herpes labialis. Now coming to the next question, patient with history of herpes simplex virus infection presented with fever, uneasiness, arthralgia, that is joint pain, which is accompanied by skin lesions on palm. And here you can see in the image, these skin lesions are shown in the image, as well as over back of the hand and feet as shown in the given image. What could be the likely diagnosis? So again a clinical question, and here they are giving a history that there was a previous history of herpes simplex virus, okay, and later patient started developing such type of lesions where over palm, over foot. So do you know any condition where after herpes virus infection such type of lesions start developing over distal extremities like hand and foot? Yes, this is a case of erythema multiforme. Erythema multiforme. Why erythema multiforme? Because if you talk about the causative agent or the cause or the etiology of erythema multiforme, in majority of the cases we don't know the cause, that is idiopathic. But if we talk about the known causative agent, the most common is herpes simplex virus infection. If herpes simplex virus infection or any viral infection is not mentioned, then you can choose drugs like sulfonamide. So herpes simplex virus is the causative agent, and that is the clue which is present here. Now what happens, that how these patients clinically present? They clinically present with target lesions. Now this is very important, target lesions. You should know how to identify target lesions. So all these you can see that these are target lesions. Just now I will explain what are target lesions and where they usually develop. Site, the common site is distal extremities like palm, hand, feet. So all these are important clues which are pointing towards the diagnosis of erythema multiforme. Now how you're going to identify a target lesion? Now all of you might have played dart. So when you play dart, the target which you hit have 3 concentric rings, something like this: a central ring, then a middle ring, and then an outer ring. So such type of rings are seen, concentric rings are seen, and that's why this lesion is known as target lesion. So here you can see that these are target lesions. There is central ring, then there is outer ring, and then there is one more outer ring. Sometimes in the central portion you might get vesicles, but generally in the central ring you will find central dusky erythema. Sometimes vesicles or fluid-filled lesions might be present, which is surrounded by edematous ring, which is further surrounded by erythematous halo. So such type of lesions are seen in erythema multiforme. These are known as target lesions, or concentric rings are seen. Here again you can see a characteristic target lesion, that is central dusky erythema or vesicle, then edema, and then erythema. Coming to the next question, they are saying 40-year-old female had flaccid bulla, flaccid fluid-filled lesions over skin. Oral erosions are also present. Now, whenever question comes on any blistering disorders, it is very important to examine that whether the buccal mucosa is involved or not, because there are certain conditions which you can exclude if the buccal mucosa is spared. On histology, intraepidermal blisters were seen. So they have made the diagnosis very easy. Why? Because they have written intraepidermal. So they have excluded all the subepidermal disorders like pemphigoid. It is a subepidermal disorder. So this is not a case of bullous pemphigoid because the lesions are intraepidermal. With acantholytic cell. So this is again a clue which is pointing towards acantholysis, that is separation of keratinocytes, and keratinocytes are within epidermis. So it is going to lead to intraepidermal disorder. And do you know of any intraepidermal disorder where flaccid lesions are seen, buccal mucosa is involved, and acantholytic cells are seen, that is acantholysis is taking place? Yes, you are correct. The answer is pemphigus vulgaris. So pemphigus vulgaris is an autoimmune condition where IgG antibodies are formed against desmoglin 3 as well as desmoglin 1, and in these cases oral erosions are seen or buccal mucosa is involved. Like you can see here in this patient, there is oral erosions and crusting, and if you examine the skin of the patient, you will get these very flaccid blisters or bulla. So very flaccid blisters and bulla, and when they rupture, because they are very superficial within epidermis, which is the topmost layer, so because they are present within epidermis, many a times they rupture. When they rupture, what they form? They form erosions. And because this desmoglin helps in attachment of two keratinocytes, when this desmoglin becomes defective, the keratinocytes separate, and this is known as acantholysis, due to which acantholytic cells are formed. And because there is separation of keratinocytes, all these keratinocytes are within epidermis, so the lesions are also within epidermis. That's why intraepidermal blisters are seen. So you can see all these are the important clues in the question which are pointing towards the diagnosis of pemphigus vulgaris. So answer here is pemphigus vulgaris. So here you can again closely see patient may present with oral erosions. So mucosal involvement is generally always present with pemphigus vulgaris. And if you examine the skin of the patient, you will get very flaccid intraepidermal blisters, which might lead to these erosions, sometimes crusting also. Now I told you that there is acantholysis, that is if these are keratinocytes, what happens that these desmoglin which are present in between the cells start breaking and the keratinocytes start separating. This is known as acantholysis, due to which the keratinocytes start separating from all the sides, and such type of keratinocytes which have separated from all the sides are known as acantholytic cells. Acantholytic cells or acantholytic keratinocytes, and these are suggestive of pemphigus. So you can see these cells. These are acantholytic cells. If you want to see these cells in a patient of pemphigus, you can prepare one smear which is known as zinc smear. So when you prepare zinc smear and if you find such acanthocytes, then it is suggestive of pemphigus. But instead, if you find multinucleated giant cells, then it is suggestive of herpes. So these are two important conditions where you can take the help of zinc smear. Coming to the next question, here they are saying 65-year-old male presented with severely itchy skin and tense blisters. See, if you compare this question with the previous question which we just now discussed about pemphigus, there the blisters were flaccid, here the blisters are tense. There was no itching, but here itching is present. And surrounding normal skin as well as articulated plaque. There was no history of any articulated plaque. Here articulated plaque is present, that is urticaria is characterized by erythema and edema. So the lesions have slight redness around them, which you can see in the image as well. This redness which is present around the lesions, and the lesions are very tense blisters as seen in the figure. What is the diagnosis? So the important clues which are present in this question are: first, old age of the patient, because pemphigus, like pemphigus vulgaris, generally occurs in the age group of 40 to 60 years, but bullous pemphigoid generally occurs in the age group of 60 to 80 years. So age group is suggestive of pemphigoid. Pemphigoid is also associated with itching, and the blisters which are formed are tense here. So tense blisters are suggestive of pemphigoid, which is associated with redness around the lesion, which is mentioned in the question in the form of articulated plaque. This condition is due to defect in BPAG, that is bullous pemphigoid antigen 2 and bullous pemphigoid antigen 1, and that's why the lesions here are subepidermal. So subepidermal blisters are seen, and the diagnosis here is bullous pemphigoid. One more important point to remember here is that when these blisters heal, so what happens, that these blisters do not easily rupture. So there in pemphigus they used to rupture and form erosions, but here they do not rupture and they might settle down. So settled lesions, so there is settling of the lesions, and sometimes at the time of healing of these blisters, milia are also formed. So sometimes these points are also mentioned. Here you can again see a patient of bullous pemphigoid having very tense blisters. Okay. Coming to the next question, here they are saying that a patient with acute history of blistering and denudation involving more than 30% of the body surface area. So very severe condition, more than 30% of the skin is involved, along with erosions which are present around lips and hemorrhagic crusting over other mucosa for few days. What is the common triggering factor? So I think all of you might have made the diagnosis by now. Yes, this is a case of toxic epidermal necrolysis, which is also known as Lyle's syndrome. Lyle's syndrome. In Lyle's syndrome or TEN, the triggering factor in majority of the cases is drugs, and the most common drug is generally anti-epileptic drugs like carbamazepine. Though other drugs are also involved like nevirapine, which is antiretroviral drug, allopurinol, NSAIDs. So multiple drugs can cause this condition, and how to differentiate this condition from Stevens-Johnson syndrome? Remember here the area involved is less than 10%, but in the question more than 30% is mentioned, so that's why the answer is 10. So 10 is a very severe condition. It is a type of emergency, and what happens when the patient takes this drug, what happens that there is lot of epidermal necrosis, lot of epidermal separation, and the patient comes to the emergency department. It looks as if the patient is having burn. So burn like epidermal separation occurs, but this is actually due to drug intake. So there is a history of drug intake, and these patients have very prominent mucosal involvement in the form of mucosal crusting or hemorrhagic crusting. Epidermal separation starts, and as this disease progresses, this separation keep on increasing and more body surface area is involved. If more than 30% of the body surface area is involved, then we call it 10. This is a very severe condition, and it is a life-threatening condition in many of these cases. Because the epidermis is separating, if you apply pressure, then it further separates. So Nikolsky sign is seen positive in these cases. Nikolsky sign is positive. Nikolsky sign is also seen positive in other conditions like pemphigus, TEN, Stevens-Johnson syndrome, staphylococcal scalded skin syndrome. So these are few conditions which you can remember when Nikolsky sign is seen positive, like pemphigus, Steven-Johnson syndrome, TEN, and staphylococcal scalded skin syndrome. A 9-year-old girl presents with annular plaque with peripheral scales. So there is annular. Annular means ring-like with scales at the periphery. Topical nystatin ointment is prescribed, but the rash is unchanged. What is the next best step? If you look at this lesion, you can clearly make out that this looks like a fungal infection known as tinea corporis, where annular lesions are seen, where there is active margins and central clearing. So central clearing and active margin is present, and that's why this looks like a ring. So ring-like lesions are seen in tinea corporis, which is a fungal condition. But remember that we use antifungal agents but not nystatin. Why? Because nystatin is not effective in tinea. It is very effective in candidiasis. So nystatin ointment is generally used in candidiasis, while for dermatophytes which cause tinea, we use anti-dermatophytic agents, commonly azoles. Okay, so you need to start appropriate antifungal with efficacy against dermatophytes, because dermatophytes cause tinea infection. What are dermatophytes? Like epidermophyton, trichophyton. So these are dermatophytes. Okay, so answer becomes A. So remember that nystatin is not effective against dermatophytic infection, but it is effective against candidiasis. So though it is antifungal agent, but we are not going to use this because this is not candidiasis, this is tinea. Remember, the drug of choice for tinea corporis, where such annular lesions are seen, is oral terbinafine. If oral terbinafine is not given, then you can choose oral itraconazole. Drug of choice for tinea capitis. If this tinea infection, that is dermatophytic infection, occurs over scalp, like carrion, which is example of tinea capitis, then the drug of choice is oral griseofulvin. So here terbinafine, here griseofulvin. Coming to the next question, here they are saying that patient presented with macular scaly lesions over trunk. As shown in the picture, what is the incorrect about the given condition? Now, whenever you are reading a question, very precisely read the language of the question. It is correct, incorrect, they are asking about true, not true, they are asking false, and except is written at the end or not. So here they are asking incorrect statement. Okay, so lesions are small, they are macular, they are scaly, and they are present where? Over trunk. Now if you look at this image, it is a clear-cut case of pityriasis versicolor, which is caused by Malassezia yeast infection. The common site is upper trunk, and this is generally hypopigmented, as you can see in the image, but sometimes it can be dark in color as well. So Malassezia furfur is the infective organism. Yes, this is a correct statement. The lesions are usually pruritic and darken after sun exposure. Wood's lamp examination shows yellowish golden fluorescence. Absolutely correct. And coupe d'ongle sign is seen. Absolutely correct. The only wrong option is B. So remember that this is a wrong option. It is generally asymptomatic. Pruritus is not a common presentation, and this statement is also false that it darkens after sun exposure. No, it is a fungal infection, so it remains as such unless you treat it. So here again you can see hypopigmented lesions over trunk of pityriasis versicolor. If you closely see, you will find scaling also, like it is present here. Scaling is there, and if you scratch this scaling with the nail, the powdery scales come out, this is known as nail scratch sign or coupe d'ongle sign. That is mentioned in the image. Now, if in the question it was mentioned, so if you scratch this lesion with any blade or with your nails, then these scales come out, and the scales are very characteristic. They are briny scales or powder like, that is powdery scales. So they are seen in pityriasis versicolor. Coming to the next question, 21-year-old football player with peeling skin and fissuring between the cleft between the fourth and the fifth toe. Which of the following is the causative agent for the given condition? So if you look at this image, the patient is having an infection in between the toes. So this is interdigital. So interdigital, in between the toes, web spaces are involved, and the most common site for tinea pedis is, yes, fourth web space. And remember, what is the another name of tinea pedis? Yes, can you tell me what is the name of tinea pedis? Another name? Yes, it is athlete's foot. Why athlete's foot? Because it is very commonly seen in athletes like football player, because they keep on wearing their shoes for many hours in a day. So they develop tinea infection over their web spaces. So tinea is caused by dermatophytes. So that's why the answer is dermatophytes. Here again you can see tinea infection, and sometimes it might progress to involve the skin as well. So it starts from the web spaces and then it might progress. Here again you can see, so in tinea pedis, again the drug of choice is oral terbinafine. If it is not there, then oral itraconazole. Here they are saying 35-year-old diabetic female. So patient is suffering from diabetes. Now you remember that diabetes is a predisposing factor for various infections. Okay, so when the patient have uncontrolled blood sugar levels, then various infection can occur. So probably this is some type of infection which patient is developing. So diabetic female presented to OPD with the skin changes as shown in the image given below. What would be the most likely diagnosis in such condition? And in the image what you can see that folds are involved. Which fold? Inframammary fold, intertrigo. Why we call it intertrigo? This word intertrigo comes from intertriginous areas. What are intertriginous areas? These are folds. So whenever folds are involved, we call it intertriginous areas are involved, that is intertrigo. And because the patient is having diabetes, this is some fungal intertrigo like candidal intertrigo. So the diagnosis here is candidal intertrigo. One of the option is intertrigo. Intertriginous areas are involved because the patient is having diabetes. There is some infection in the intertriginous areas, and that infection can be candidiasis. Why? Because candidiasis and diabetes have a correlation. The diabetes predisposes for candidal infection. Another important clue which you can see in the image is that this is the lesion which is present here, and around the lesion these smaller lesions are also present. These smaller lesions which start developing around a large lesion are known as satellite lesions, and satellite lesions are also characteristically seen in candidiasis. So again the answer is candidal intertrigo. A child had multiple itchy papillary lesions on genitals, fingers. Similar lesions are also noted in younger brother. What is the diagnosis? So multiple itchy papillary lesions where over genitals and fingers. Now remember that papillary urticaria can also occur in children, but it generally occur over exposed areas, not over genitals or hidden areas. Scabies occur over genitals. It can occur over fingers, that is web spaces. The lesions are itchy. Lesions can be papillary, and it have family history as well. So younger brother is also infected or having the same condition. So this is one condition where all the clues are pointing towards. So answer is scabies. Atopic dermatitis occur over flexural areas and genital involvement is not very common, and allergic contact dermatitis generally occur over exposed areas. So with the site, you can very easily make out that this is a case of scabies. Okay, so these are very important clues which you have to take from the question and then mark the answer. So here is a patient suffering from scabies where papular lesions, very itchy lesions, start developing over web spaces, other flexural sites, and the most characteristic lesion which looks like S is burrows. So burrows are the most characteristic lesions of scabies. A boy presents with erythematous scaly papules with crusting over antecubital fossa. He was applying petroleum-based emollients in the shower. What is the next step of management? Now, if you look at this image, can you make out what is the diagnosis? Yes, the important clue here are that the lesions are present where over antecubital fossa. So atopic dermatitis, which is again a very itchy condition, very chronic condition, and it generally involves flexures, that is cubital fossa and popliteal fossa. Okay, so probably this is a case of atopic dermatitis, and here we give emollients. So emollients are being applied. Now what you are going to do next? Decrease the frequency of this petroleum jelly? No. Decrease the frequency of shower? No. Mupirocin 1% topical application or triamcinolone cream. So remember, mupirocin is antibacterial. So if there is no infection, there is no role of mupirocin. So this is preventive. If there is infection, then we will give. But because this is dermatitis, topical steroids are very effective. And one topical steroid is triamcinolone. So triamcinolone can be used for application or the treatment of this condition. Here again you can see cubital fossa or popliteal fossa are commonly involved, but in children generally face or extensor involvement can also occur because when they crawl their extensors can get involved. So this is the face involvement of atopic dermatitis seen in a child, but in adults generally these are the common sites, that is flexus, cubital and popliteal fossa. Central facial erythema with overlying greasy scales, greasy yellowish scales as seen in this patient. So site involved is face, and over face greasy lesions are present, and all of you know greasy or oily lesions are why? Because of the oily secretions of sebaceous glands which can get involved in seborrheic dermatitis. Yes, the answer here is seborrheic dermatitis. Nummular eczema. Nummular eczema is coin-shaped eczema. So when the eczema is coin-like, we call it nummular eczema. Dyshydrotic eczema is also known as winter eczema. And pityriasis rosea, all of you know, is a condition where colorate of scales are seen. So all these points are pointing towards seborrheic dermatitis. Remember, when seborrheic dermatitis occur in infants, such greasy scales can be seen over scalp, known as cradle cap. So this is seborrheic dermatitis seen in infants. So I hope this session was useful for all of you. Thank you.